This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV. This Week in Virology, episode 1192, recorded on February 13th, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
It's quite a bow tie you have there. It's very splashy. What's that?
This is my Ebola, my filovirus bow tie.
Cool. It's timely.
It's one of my favorites. All right, we got a lot to cover. Oh my gosh! But first is it's a tribute to Dixon, right? I don't know if our listeners are aware, but we lost a really good friend, colleague, mentor, my parasitology professor from medical school, Dixon de Pomier. So,
wow.
So I have a poem here, Robert Frost. Nothing gold can stay. I think Dixon would like that. Nature's first green is gold. Her heart is you to hold. Her early leaf's a flower, but only so an hour. Then leaf subsides to leaf, so Eden sank to grief. So dawn goes down to day. Nothing gold can stay. And really, Dixon was really a special individual. So it's going to be, it's been a hard loss. It's been a hard loss.
Dixon was with me on TWiV since 2009. And then he started TWIP with me. And then Daniel joined us on TWIP. And he's been on, we did urban agriculture for 30 episodes. And he's been on live streams as well. So Dixon and I and Microbe TV go back a long ways. I'm going to miss him because he was really a good conversationalist.
Oh, his stories. I met Dixon in 1993, if you can remember that. And I remember when we met again at Columbia, and I was like, you know what? Not only do I remember you, but I can tell you what you had for lunch the first day you lectured to me. So I was always a very memorable guy with him. He was, of course, he had sushi and was talking about, parasites. So.
Yeah.
All right. Well, I will just mention, I'm sure everyone's aware, but RFK Jr. was confirmed as HHS secretary. So we'll probably be talking a bit about the impacts that might have on science.
I think it's a bad
but let's get into the science.
Daniel, I think it's a bad day for science. I think to have a non-scientist.
It's going to be really interesting to see how a man who doesn't embrace germ theory or vaccines is going to meet the challenge of bird flu, right? So we'll get into that. Or everything else that we'll talk about. So mpox, remember the new clade that's spreading among children in Africa, clade 1B. New York State officials have confirmed clade 1B in a resident. The first such case in New York State, the fourth confirmed in the United States. So we have the new mpox. Ebola. From the AP, we heard Tuesday. We're going to get updates like Tuesday, Friday, I think it is. Maybe less often, but we heard from the AP that Ebola cases in Uganda are up to 9. 265 are being monitored. 7 patients were admitted to the main public hospital in Kampala. There's another being treated in the Eastern District of Mbale, right? That's the Mbale Regional Hospital, not far from our clinic. And the one other patient, if you do your math, is not survived. So we will see what happens. I'm not sure we're going to get a lot of frequent updates here, so we'll share what we can. Maybe this goes back to that first announcement, but how do people in the U.S. feel about vaccines? The Partnership to Fight Infectious Diseases released results of a public opinion poll that reveals that, I'm going to use the word most American voters, regardless of political affiliation, support the continued availability of FDA-approved vaccines, express concern over declining childhood vaccination rates. But I say most, but what were the key findings? 74% of American voters believe the U.S. should prioritize ensuring FDA-approved vaccines are widely available to everyone. That means 1 in 4. That means a quarter of Americans don't really think that that's a priority. 81% of voters say it's important for the U.S. to remain a leader in developing new vaccines. Apparently, 1 in 5, 20% of folks say it's really okay if we sort of fall behind. 70% of respondents expressed concern over declining vaccination rates among children, which means about a third of folks here in the U.S. are okay with dropping vaccination rates. So let's use that as a backdrop for what we're going to talk about today. Measles, one of our many things. So far, confirmed cases in multiple states, and it's only February. So Alaska, Georgia, New York City, that's not a state, but okay. Rhode Island, New Mexico, and Texas. So half a dozen states were already having outbreaks of measles. Some of the outbreaks of these vaccine preventable diseases are in Texas and Georgia. Now, the CDC says they'll give us monthly updates. You only need to know about this like once a month. Measles elimination is where there are no locally transmitted measles infections or outbreaks for at least 12 months in a specific geographic area. This means that the disease is no longer endemic in that area. Measles was declared eliminated in the United States in 2000, but it actually appears to be back due to dropping immunization rates. We think it's due to dropping immunization rates. Other people think it's due to bad character, wet hair, and other, character flaws. Measles outbreak expands in West Texas around a county with low vaccination rate. I'm going to talk a little bit about this. So we've got this measles outbreak in a rural area of West Texas where vaccination rates are well below the recommended level. It starts in late January. 2 children in Gaines County are hospitalized for measles. Just mention that. Children in the hospital for this disease. The state health department shared an alert that the number of confirmed cases had grown to 6. Then it was up to 14. Now we're at 24 confirmed cases, all unvaccinated. And we are told that the West Texas Department of Health will be giving us updates on Tuesdays and Fridays if there are new cases to report. And I want to point out, just where are we with measles? There are almost 300,000 kindergartners in the United States who do not have documentation of an MMR vaccine. So just to give a little bit of backdrop here, measles cases in the United States back, we'll say 1960, there were 500,000 measles cases in the United States every year. Someone who recently was confirmed as the HHS made some comment, yeah, but only like 1 in 1,000 die. Well, if you got 500,000 cases, that's 500 dead children a year. So I just want to point out, that's what used to happen in the United States before the vaccine was licensed. When the vaccine was licensed, that number dropped to the numbers that we're now seeing. But unfortunately, to maintain that herd immunity that people are familiar with, you really need vaccination percentages at 95% and above. We only have about 12 states left in the entire United States that are above that 95%. And we have dozen states that are actually even below 90.
Daniel, there was a compassionate statement that only 1 in 500 kids die.
I thought his thing that he does that. So he takes a number and you say, okay, 500,000 cases of measles, instead of pointing out that that's hundreds of children dying each year, instead of pointing out that's hundreds of children, thousands of children ending up in the hospital, children surviving with blindness or brain damage or other things, he throws out 1 in 1,000. I think he actually said 1 in 10,000 and try to minimize that. So, but when you live in a country of 350 million people, 1 in 1,000 still adds up to hundreds, if not thousands of people. Okay, so just be careful when someone just throws those statistics at you. Say, forget about your statistics. How many hundreds of children are going to die or end up in the hospital? All right, bird flu. We got some interesting things here, interesting and troubling. So a second type of bird flu, right, is circulating in U.S. ducks. This is this H5N9. So we read in Scientific American that H5N9 is a highly pathogenic avian flu or bird flu that bears some structural similarities to H5N1. Now, there's low pathogenic H5N9 viruses that have previously been detected in birds in the US, elsewhere, and this goes back to the 1960s. However, these infections are usually associated with less severe symptoms than the highly pathogenic strains. Now, this is the first time that there's a highly pathogenic H5N9 seen in the US, and some experts suspect that H5N9 may have emerged among the ducks in California due to genetic reassortment occurring between circulating H5N1 and other flu viruses containing the N9 protein, right? So we've got the H5 and the N9. Those are the two proteins found on the surface of the virus, and that's what gives the different flus their subtype names. So I thought, Vincent, this is a great time for people to understand this H and N naming system. In fact, people always hear H1, N1, and all the rest. Well, the U.S. Centers for Disease Control and Prevention, Friday, February 7th, reported a variant H1N2 little v infection involving an adult in Iowa, the nation's first variant flu case of the 24-25 season. So, all right, what's going on? H1N1, H1N2, H1N2 little v, the 9s, the 5s. So, high level, we have 1, 2, 3, I would say 4 main types of flu. We've got flu A, we've got flu B, flu C, and flu D. And not to get confused, we're going to talk about some of these letters again. Now, we say the general teaching is that flu B circulates at low levels in humans all year, and that flu A is the epidemic flu that we see in the northern hemisphere each winter. Flu C and D are minor players. You can forget about those for the moment. I will just say that flu B actually has a little bit of a hump as well. It's a respiratory pathogen as well, but it's not the main one that we see causing the thousands of people that die each winter, the 100 children that die each winter, tens of thousands of hospitalizations, etc. Okay, so flu A is the big one that we're worried about. It's the one with animal reservoirs, and then there are different types of flu A. And we classify those, the first sort of classification of flu A is by the H and the N. And don't worry, there won't be a test on this. We'll keep coming back and telling you more. So H is for hemagglutinin. Think of this as the spike on the surface of that flu, and it binds to that sialic acid receptor. And the N is for neuraminidase. It's an enzyme that allows the release of new flu viruses from the cells where they're manufactured. And there are a bunch of different H's and a bunch of different N's. We've got 1 through 18 for the H's. We've got 1 through 11 for the N's. And we started our counting back with the 1918 Spanish, or I like to be honest and call it the Kansas flu. So that was H1N1. And then we start to count up from there. So the types of flu that are commonly circulating in humans are the H1N1. There's actually an H1N1 2009, right? That's a little more severe. And the H3N2. So in this report, we have an H1N2, and we recognized 9 of those variant flu A cases last year, about half being the H1N-V. So this little v is a variant, and we see a few of these, maybe 9 or 10 each year, and these are not transmitting person to person, so this is from a pig probably. But in this case, where someone had an H1N2 variant, there was no pig exposure. All right. Is that clear as mud for everyone, Vincent, you think?
Yeah, it's good. It works for me.
Okay. Okay. So we do this thing. It's really interesting, right? So when when someone asks, what flu do I have? So there's the flu type A, and then we don't do this as much in humans, but the place where the virus was isolated. So you might have an A Sydney, and then there's a strain number, a year it was isolated, and then finally we get into what most people are familiar with. So H1N1 or H3N2, right? So we're all good there. This is going to be helpful going forward. So bird flu suspected in deaths across multiple species at Queens and Bronx zoos. So unfortunately, the bird flu, it's here in New York, and the avian flu has recently killed as many as 15 birds at the Queens and Bronx zoos. 7 bird flu cases were detected in poultry markets in Bronx, Queens, and Brooklyn. There are roughly, I don't know if you knew this, but there are roughly 84 live bird markets in New York City.
Yeah, I know.
Kinda
it's amazing.
wild, right?
You can go in and pick out a chicken and bring it home.
Yeah, I mean, I felt like back in China, right, where in the markets like that, I would like that, and they'll actually cook it up for you right there. Not in New York. New York, you got to do it yourself, I guess. But it's really interesting. So, so they decide like, hey, we've detected this, avian flu in the poultry markets. We got to shut all these down. But what do you do if you're a savvy poultry seller? You try to sell them all off quickly at a discount. I kind of think they should have just shut them down right away, like, right? Selling off chickens that might have, all right. Also, a deceased flock of Canadian geese found in Mount Pleasant. That's about 16 miles from the Bronx Zoo, and they think that they were actually avian flu deaths. Lots of news and questions about cats getting the flu. So far, 80 domestic cats with a confirmed bird flu infection. And we really do not know if one of those cats gave it to a person. Nudge, nudge, wink, wink. I'm going to leave in a map it's really a great map. And this is all the different animals and all the different areas. So these are wild and captive mammals that have been infected with the highly pathogenic avian influenza. So we've got captive wildcat, domestic cat, wildcat, bear, wild canine, marine mammals, raccoons, rodents, skunks. There's a opossum down in Virginia, a Virginia opossum. So
Daniel, which clade are these? Are these mainly the cow clade or the avian clade?
Okay, so this is where it gets really interesting, right? So everyone's like, okay, so I've got flu A, and I'm just only going to worry about that for the moment. And then I know we've got the H5N1, and that's the bird. But then we talked about these two genotypes, right? Two types of H5N1, two types of bird flu. There's, as we told people last time, there's a clade B for bovine, for benign. And then we talked about when it spills directly from the birds, and that's mainly what this is. This is H5N1 clade D. But now life gets complicated and also gets really interesting. There was a second spillover of H5N1 into dairy cows in Nevada, probably half a dozen herds. This time it was clade D. Now, a person got that clade D. So nature did this really interesting experiment for us. So H5N1, now it's clade D, it gets into the cows, the person gets it, and now we're left to wonder, is there an attenuation when it gets into the cows before it transmits to the person, or is the clade D that directly from ducks going to be deadly? And the illness in this case was considered mild. The person ended up just with eye redness, irritation, and they got better.
Daniel, the clade D in cows, is that a mild infection?
In cows, it's mild. In people, it's mild. In the birds, that's the deadly one.
Okay.
So it's interesting. So you can now get not only clade B bovine benign, but you can get clade D from the dairy, and it's also benign.
Right.
So interesting. So I guess, nature did that experiment where it gained function, like with the ferrets, right, where it can now transmit among the mammals or transmit through the air in the experiment, but it also had the same loss of function. By gaining one, it gave up the virulence.
So what you're referring to is that...
when you get it directly from the birds, you get sick and die. If you get it from the dairy, you don't get so sick.
So this clade D is transmitting among cows, but it's not lethal. It's mild.
It's transmitting among cows. It's transmitted already from the cows to a person, right, but it's not lethal to the cows and it's not lethal to the person.
Okay.
So somehow it got attenuated.
Which is good. Loss of function.
Yes. Yes. Gain and loss. All right. So that's the avian flu. Now let's go into human flu. And things are bad. Not only are we still at high levels, but flu season in the U.S. is the most intense it's been in at least 15 years. So we can look at it in different ways. One is the percentage of doctor's office driven by flu-like symptoms. And last week, the number was clearly higher than the peak of any winter flu season since 2009, when a swine flu pandemic hit the nation. And this is data from the CDC. So far this season, the CDC estimates there have been at least 20 1.4 million flu illnesses, over 300,000 hospitalizations, 13,000 deaths, including we're up to 57 deaths in children. And now the CDC declined to speak to the Associated Press reporter who called them because we, as you know, we have this temporary pause on communications. And this is something that really has never happened before. You can look at a map, and there's actually more and more of this as high as it gets influenza activity across the country. Texas is a mess. Most of the country is in high or very high levels. We had another 10 influenza deaths in children just last week.
Daniel, these deaths and hospitalizations, are they generally in unvaccinated people?
It's almost all. So like 90%, this is sort of the historic number, 90% of the deaths tend to be in unvaccinated individuals. So it's really tough. I mean, I always have that discussion with people, right? Because they're like, I got the flu shot. What's the point? And I do say, but did you die? And that's really the big thing. Flu shot is not going to keep you from getting infected, but it will have a big impact on severity. All right. And also, if we care about our neighbors, the more people that get flu shots, the less other people get the flu. So, and I'm just coughing because it tickle. I'm not dying of flu or anything, just to let people know. Okay, RSV. RSV level still high. And we have a nice article here. I would try to reinforce that, RSV, it's not just for children. And we have the article 10-year surveillance of RSV hospitalizations in adults, incidence rates, and case definition implications, published in JID. So prospective, multi-center, observational study, active monitoring over 10 seasons at either 4 to 10, sort of depending on season, 4 to 10 hospitals. It covered 21 to 46% of the region's total population. So we're looking at a population of about 5 million people. The RSV hospitalization IRs per 100,000 were calculated. They have two case definitions. They're looking at influenza-like illness and the combined of influenza-like illness, and they document that it's severe acute respiratory infection. End up with a total of 40,600 hospitalizations of individuals age 60 and over. The incidence rate was between 21 and 402 per 100,000 person years, varying by season, age group. The highest was in the oldest folks, so 80 and older. Basically, what they calculate out, this sort of seems like the magic number, 1 in every 1,000 adults, 60 and over, will end up hospitalized due to RSV. So just to put that number. And so since we have a lot of folks over 60, you're really going to end up with a lot of individuals hospitalized. In the United States, RSV infections cause an estimated 58 to 80,000 hospitalizations among children under 5, and 60 to 160,000 among adults 65 and over each year. RSV leads to over 2 million outpatient visits annually in the U.S., and there are between 100 and 300 deaths in children under 5 each year, and for adults 65 and over, 6 to 10,000 deaths annually. And remember, this is now a vaccine-preventable illness. We have passive and active vaccinations for the high-risk individuals. All right, COVID update. This is, I think you and I were talking about whether or not there would be a surge, and then we had a surge. We said, okay, but I don't think anyone thought it would start to go down and then surge back up again. And yes, SARS-CoV-2 activity when we talked today is higher than when we talked a couple weeks ago. We have several areas of the country where 1 in 25 deaths are due to COVID. And if you follow the wastewater, we are actually in the Northeast, we're already higher than we were back in the end of December. We are on this exponential rise again. We're really driving it across the country.
Do you see this in your hospital, Daniel?
We do. We have a lot of admissions for respiratory infections. We have the COVID, we have the flu. Yeah. So certainly seeing it. I was talking to one of the ID docs, we don't want to tell too many people how bad things are, because then the worried well will start flooding our gates. But yep, it's bad out there. So, be careful, make wise decisions. As we mentioned, right? I mean, for particularly folks, 65 and over, people with risk factors, under the age of 6 months, right? So the new kids coming into the world, we're still seeing over 1,000 deaths a week, and we're seeing thousands of hospitalizations. And how do we prevent this? Well, one, don't get infected, get your vaccination, and then early treatment, right? If you end up getting tested positive, I was talking to a friend of mine today. He started his Paxlovid, started to feel better, so he stopped, and he got much worse and finished his Paxlovid. We talked about how not to do that next time, to do it, just take it, start it as soon as possible if you're at risk. We also have remdesivir, molnupiravir, convalescent plasma. And yeah, remember, you're contagious. So when you get it, you can then give it to your loved or not so loved ones. Second week, we see people both. We see people in the first week having a tough time, but we still see people in that second week requiring oxygen support. And this is where we look at steroids, anticoagulation, pulmonary support, remdesivir, and in some cases, immune modulation. And the bane of our existence, and unfortunately, I'm going to share this. I got a really disturbing email. There are a number of long COVID research projects going on, and we actually got an alert at Columbia. I got shared on the email today that the CDC, which has been partnering with us on that, may not be able to continue to support that research. So, unfortunately, some of the people that are now going to be involved at HHS have made it pretty clear that they feel like it is a waste of time. It is a waste of resources to focus on understanding what's driving long COVID. So, write those letters to your representatives if you think that we should prioritize understanding long COVID and finding treatments. So a couple articles here. The article, Long COVID Incidence Proportion in Adults and Children Between 2020 and 2024, published in CID. Another study trying to sort out long COVID incidence. It's an EHR-based retrospective cohort study looking at adults and pediatric patients, folks with documented acute SARS-CoV-2 infection, and then 2 control groups, contemporary COVID-19 negative and historical. They examined the proportion of individuals identified as having symptoms or conditions consistent with probable long COVID. And one of the challenges they mentioned is not having a standardized definition. But what I like what they did is they were looking at excess incidence, right? Because there's a lot of background, and you don't want to say everyone who has these symptoms now has this as a diagnosis. But so when they reported the excess incidence, they actually reported 1.5% for children, 5 to 6% among adults. So this calculates out to over 1 million children and millions of adults just here in the U.S. So
and really
big numbers. You say, it's only one or what's that, Vincent?
And CDC does not want to support research on this any longer. That makes no sense, right?
I mean, I think the CDC and the people at the CDC do, but their overlords are not considering this a priority. So, all right, got another one. Maybe this, if that didn't bother you enough, we have the really disturbing article, and this is consistent with some other ones, but now we're looking at our sperm effect of SARS-CoV-2 infection on sperm telomere length. We talked about an article a while back where they were looking at how folks with severe COVID ended up with shorter telomeres. Well, here's your sperm with shorter telomeres. And this was published in the Journal of Assistive Reproductive Genetics, case control study. 56 men with and 56 without prior COVID infection, 18 to 45, these are young men. Semen analysis and hormonal levels were evaluated. And they actually assess telomere length, right? So telomeres are these pieces of DNA at the end of your chromosomes. And basically the whole idea is we start off with a certain length, and as we get older, the telomeres get shorter and shorter until we finally succumb. And they actually found that the folks who had gotten COVID-19, their sperm had shorter telomeres than the folks that did not get it. And actually, most of these folks, these were asymptomatic or mild illness. And this is 90 days. This is 3 months after they were all better.
So what does it mean that your sperm has shorter telomeres, Daniel?
I don't think we know, but, but it is worrisome, right? Because you're thinking like this is the sperm that's going to get together with the egg, and that's going to lead to the child. So what is this going to, when we start looking in the newborns, are we now going to have generations of people born, with like shortened telomeres? And what will
it also may just lead to sterility, so you don't have to worry about that.
And also, I would love to know, is being vaccinated protective against these short telomeres in your sperm? So,
right.
All right, one more article, and then I'll get on my soapbox a little. So, the pediatric gastrointestinal tract outcomes during the post-acute phase of COVID-19, published in JAMA Network Open. And here they looked at a cohort of 1,576,933 pediatric patients. They report that children and adolescents with documented SARS-CoV-2 infection faced a 25% higher risk of newly diagnosed GI tract symptoms and disorders during the post-acute phase compared with those without SARS-CoV-2. So absolute, we're talking about a 2%. So this is actually in line, 1.5, 2%, above background of these kids having ongoing GI symptoms. This could be constipation, this could be bloating, this can be pain. And unfortunately, I've been involved in the care of some of these kids. Really, really tough to treat. So, all right. Long COVID. So low and middle income countries, we've been saying for a long time, and maybe we're headed towards a lower middle income country ourselves. No one is safe until everyone is safe. We're in the middle of our Floating Doctors fundraiser, where February, March, April will double your donations up to potential maximum donation of $20,000. And an update from Panama. Last week, they did the clinic in Playa Verde. That's a community I visited a couple times, even with my daughter. In addition to being one of the longest visited communities for Floating Doctors, it's one of 3 communities where Floating Doctors has hired local midwives, parteras, to receive ongoing training and assist in monitoring pregnant and postpartum mothers and their infants. During the 3-day clinic this time, they saw over 200 patients, including multiple house calls. One of the patients is pregnant with twins, and because of the higher risks associated with multiple pregnancy, this local partera is going to monitor the health of mom and the babies and report weekly with any alarming changes. And this is just the good work that's going on down there. So go to parasiteswithoutborders.com, click on donate. It's through your support that we can continue to help them do this great work.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Genevieve writes, I love your podcast and really appreciate all the info you provide. I have a question about avian flu transmission to pets. I like to walk my dog along the shore, and on occasion we may encounter a dead seagull or duck. I try to avoid these situations, but my dog is very curious and has such a good sense of smell. He's a hound that he will usually detect something before I do and is eager to explore any carcass he may find. Should I be concerned that he may contract a virus from an encounter such as this? Would it be prudent to avoid the shoreline during an outbreak? How would I even know if avian flu is prevalent in shorebirds or waterfowl in my area, southern New England?
Yeah, so Genevieve, so excellent question, right? And I often will take our dogs for beach walks, and oh my gosh, if they find a dead animal, are they excited? And some, not just to smell it, there seems to be this rolling in the carcass, so it becomes this whole, get the leashes, get the dogs, and try to tackle them before they can roll. And actually, I have to say, the last time we were on the beach, there were a significant number of dead seagulls, so really concerning. Now, felines, cats tend to be the most at risk from the avian flu, right? There's a 50% or more higher mortality, we think, in sort of the cases of cats that are getting the avian flu, even when they're getting it from the cows. So even whatever attenuation relative to us and the cows. So yeah, I think that, if you're noticing a lot of dead birds, leash up those dogs, keep them away from the dead birds.
Harry writes, I followed your weekly podcast since 2020 and always learned something new and interesting. Thanks to you for doing this for everyone, and to Vincent Racaniello for making it possible. I learned on your new podcast that Paxlovid is now packaged for persons with various types of renal impairment. What about those of us on Eliquis for paroxysmal AFib? My cardiologist says to take remdesivir, which is sometimes hard for me to get and difficult to take compared to taking a pill. I've found several conflicting guidelines on taking Paxlovid while on Eliquis. One says just stop taking Eliquis for a few days, as I've done several times for medical procedures. Another one says cut the dose in half to 2.5 mg for a few days. What do you advise if I catch COVID? Other than taking Eliquis and blood pressure meds, I'm generally quite healthy for a 78-year-old man.
All right, so I'm gonna do this in real time for everyone. So what I tend to do when a person is on a medicine is I will go to this website, which is the liver pool, and I'm gonna actually go to COVID-19-druginteractions.org. And then what we're going to need to know is we're going to need to know the generic name of Eliquis, which is going to be apixaban. So I'm going to put apixaban in here as the co-medication, so APIX. I'm going to put in nirmatrelvir, and then it's going to say potential interaction. And then what's really nice is we click on there and we'll see what it has to say. And it's going to guide us through this. It's say for apixaban doses 5 milligrams or 10 milligrams twice daily, just reduce the dose by 50% in patients already taking 2.5 milligrams twice daily. Avoid co-administration with Paxlovid. So basically what you can do is you can actually drop that dose in half. So that's what I'm going to recommend. When you're in a situation here where it looks like it's worth your while, if you're a high-risk individual, you can navigate most of these. So I guess, next time you have to actually tell us what the dose is, and then we'll tell you exactly what we would recommend in a situation like that.
Ellen writes, my husband and I, both close to 80, got the senior flu vaccinations in mid-November. Given the current rampaging flu, especially in the South where we are, and the vaccine's waning effectiveness, such as it is around 50%, should we try to get a supplementary flu vaccination? Is it allowed or prohibited? Will Medicare pay for it? Is it expensive? Thanks for all you do.
Yeah, so this is a great question. And so I got my flu shot back in October, right? And so, and you point out exactly that there is this drop in time. So November, December, January, we're now in February, we're 4 months out, right? So that's down by 15, down by 30, down by 40. You've lost about 50, more than 50% of that temporary protection. So actually today I went to Stop and Shop and I was going to get myself a second flu vaccine because there's so much flu, right? It's the worst we've had in 15 years. They were sold out of flu vaccines. So, that's sort of the first thing, is that there is this concern. Now, is there evidence? Have they done studies where you go ahead and give people that second dose and show that you're getting, additional evidence-based protection? No, we're just sort of extrapolating from this drop in protection. And particularly when, the flu hasn't hit and, we're approaching March, right? And we're probably going to approach March with just the fact that we have such high levels. The next is this cost issue. Will Medicare, will the insurance companies pay for it? That's going to depend, right, based upon the insurance company. And the others is how expensive. What are they going to charge you? So that I'm not sure. And again, it's going to depend. Maybe it'll be $100 for that extra flu shot.
Chris writes, as a former molecular virologist, PhD Fred Hutch, I enjoy TWiV and the clinical update every week. As a non-clinician, I have a question about detecting dengue. In the fall of 2019, I returned from East Africa, Rwanda, Kenya, Tanzania with my wife. About 48 hours upon arriving home, I got a fever of 103 and ultimately ended up in the ER for 3 days with fever over 104, crushing pain in joints and shin bones, but no rash. Our small town tested for flu, RSV, malaria, usual suspects, but waited on dengue because no rash. Then days later, finally sent out blood for dengue. Days later at home, I got the results. No malaria, but a perplexing dengue response. I had no IgM, but a low-level IgG. No IgM tells me I may have been infected prior in Cuba, but the low IgG makes me wonder if it was just some cross-reactivity. Now my question, is there a clinically available test that would definitively confirm a previous dengue infection? I'd be fine paying out of pocket to know, as we love traveling but have avoided many tropical locales. We'd love to travel the tropics without rolling the ADE dice.
Yes, this is a really good question. So, is there definitive? So, nothing is definitive in medicine, and I understand. So, sort of everyone, what are we thinking about here? So, the concern here is you get dengue. There's 4 types of dengue. Despite a publication at once, there was a 5th. We're just going to say there's 4, and the idea would be that you get, let's say, a dengue type 1. And then the antibodies start to drop, and now you get infected with a dengue type 2, and you end up with this actually antibody-dependent enhancement, disease enhancement, because of these low-level antibodies, which rather than neutralizing the virus, are actually going to allow the virus to get into cells because it'll bind to FC receptors, the whole deal. So yeah, that's this concern, right, is that we've always been taught that a large number of dengue severe cases are because a person gets a repeat infection with these low levels. There's cross-reactivity here with other, it's flavivirus, right? So you're going to get cross-reactivity here. So nothing's going to be 100%.
Anonymous writes, thank you for the work you and the rest of Microbe TV does. Your podcasts are a vital tool for spreading accurate scientific information. In TWiV 1188 Clinical Update, you mentioned an ongoing TB outbreak in Kansas City, and I wanted to share some information I have as an employee at CDC. For my safety and job security, I need to remain anonymous. For the past several months, CDC has been supporting contact tracing in this outbreak with boots on the ground in Kansas City. Based on what I have heard from trusted colleagues, the case investigations there are so backlogged and understaffed, the investigators are still following up on exposures from a year ago. Since the new administration began, all external communication and all travel was suspended, effectively ending this federal support in controlling the outbreak. At this time, there is no clear timeline for if and when CDC staff would be able to return to support response operations in Kansas. I thought people should hear about the real harms caused by this administration's policies.
Yeah, I mean, it's really tough, right? Here we're seeing issues like this right at home, right? We have the worst, TB outbreak in recent history, and we're hearing here, firsthand that the CDC and the federal support is really not there to help us. There really were some interesting things about avian flu. And, we've been talking about this now for weeks. And I think people are finally, going to Costco and, hey, there's no eggs on the shelf. And unless you were listening to TWiV, you're all surprised and wondering what's going on. Around the world, that freeze on federal aid, forget about, influence in the region. It's real harm. Children are already dying. I just don't see how, those of us who have a moral conscience are okay with what's going on. Wait and see what pans out. No, people are already being hurt. People are already dying. People are already not getting access to the health care. There's already real harm on the ground.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Thank you, Vincent, and everyone. Be safe.